Well, good afternoon, everyone. Thank you for joining our D2D webinar today. This is the last webinar of this sequential monthly series that we're going to be doing. We are, because we've listened to you, going to be setting up quarterly webinars, quarterly podcasts, because we were wondering if this would wind down, and the response that we got from you was, hell no, we want more of this. We want to keep doing it. It's working. It's something to look forward to, and we're learning from each other, which is what we sought to do when we started this process, that we would get better at this and we would get better at it together as a full team. So our agenda today is not about us talking, but working with you and getting your ideas. We put out a communication. Hey, bring a case, bring an experience, bring whatever you have that you learned or that you saw or that frustrated you, and bring it and let's talk about it. We were a little ambiguous on how to exactly do it. So for my team, do we want to break into groups or work with where we are?
I think we could break into 3 groups, 12 people each. And one of us goes into each group, and we can do that for, let's say, 20 minutes.
Perfect. So we're gonna jump into groups like we did last time, because that was really awesome. It was really great to talk to you guys face to face and person to person, and then report back on what we heard and learned. And so we're going to try that again. So Alicia, if you want to put us into 3 groups, that would be awesome. And then we'll meet back at 5 of the hour. So everyone, Alicia, we have everybody back?
Yep, we're all back.
Perfect. So welcome back, everybody. We had a great time in our group. Why don't I take just a couple of minutes and I'll give you an update from my group, and then the folks who had the other 2 groups could give a quick update also. We actually didn't talk about specific cases. Our group was so excited to share what they've been doing with D2D and how they've been working it into their practices, and beyond their practices into state medical organizations and getting papers written. It was awesome. Such things as Cheryl Hutchinson had an 18% reduction in her facilities and presented that to the Michigan Medical Michigan Medical Directors meeting. She used dashboards to keep that the pharmacist drove to keep everyone on track, and worked with families, care conference. Some of these we heard last time also. Families were part of the process. Geriatric fellows were also presented. One of the things that came out that I wanted to make sure we shared, Cheryl spoke about geriatric fellows. Myra spoke about the use of students, pharmacy students, to pull data, to look for folks to intervene with, the use of students, free labor, who need the experience to help drive D2D. Deb Melito a pharmacist would take our slides right back to her centers and present them as part of quarterly QAPI. And again, I'll leave it there. Just incredible use of what we did together, and to my team, there's a strong urge to keep this going. So that was the message that I heard loud and clear. Who's next?
Well, I can be next.
Thank you.
We had a great group, I thought, and we did actually talk about cases and or individual approaches, and I think it was really impressive. So Marek is a practitioner who has been only listening for the past 3 months, but he proceeded to tell us all the medication that he has successfully discontinued, including anti-epileptics, antihypertensive, and statins. So really going through almost the entire smorgasbord of opportunities. And I was just really, and does it every patient. And this sort of consistent making it part of the patient approach, I thought was incredibly impressive. So really, really good job. He also said that anticoagulants should be a future topic. And I made a note of that. I think aspirin, clopidogrel, what's the best, DOAC, I think those are all, how long to do a DOAC, that's a great topic. So I am voting right now to do that in our next quarterly meeting. We had an incredible case, a really very interesting case from Poonam Bhagia. And it was the case of a patient who had, as an outpatient, severe exacerbations of COPD, and finally got to the nursing home setting in a more structured environment. And she had been on multiple antibiotics, including very high dose steroids, chronic suppressive antibiotic therapy, among others. And what really, I think what Poonam recognized was that this was likely because she hadn't been compliant. And now that she was in a setting where she would actually get the medications, she really didn't need many of, especially the higher risk medications. And I thought that was an interesting case, looking at patients who come with very complex medication regimens for a disease that is really out of in the left field, and come with those into our facilities, and considering maybe this patient is non-compliant or not taking the meds in an outpatient basis, and maybe that's why they're on all these meds. And she told us on how, been carefully in communication with a specialist, how she has been able to withdraw from 20 milligrams of prednisone to 2, no more prophylactic antibiotics, and really, I think, a great diagnostic acumen there, seeing that this was really what was going on. And wow. I think in a setting where we are still having people having to choose between food and medicine, unfortunately, we shouldn't underestimate that sometimes happens. And Dr. Heimowitz was giving us a really good, he talked about how much work it is to do med reconciliation on admission. We talked about maybe a potential AMDA initiative, talking to the hospital associations. Don't just dump these patients in with all these meds. Be thoughtful when you discharge them. And who was it that said that they are a nurse in assisted living, and they see that people are gone for 3 days and they come back with an incredible amount of extra meds. And there is just there seems to be very little discipline in the hospital setting. It's probably so much easier to just discharge them with all the meds than thinking about what meds do patients really need. So I think this is another potential initiative that we could do. And finally, Dr. Heimowitz was also, there was Donna Torsen is from a QIO, and I'm really excited about this one. And she is trying to support deprescribing in her QIO region. And one of the thoughts was, well, how do nurses actually like it? And then Dr. Heimowitz said, why don't you, when you start on a deprescribing campaign, why don't you do a nurse satisfaction survey before and after? I thought that was brilliant. So it's easy to do, probably. You just keep the questions very simple. How do you like your med pass? And how satisfied are you with that, or whatever? So I thought that was great. Yeah, so that's from our group. Great group.
That's great. Thank you. Jennifer, did you have the third group?
Yeah, I did. Our group focused mostly on what sessions were helpful, what sessions we still needed, and some of what was said in my room, was already said. It's clear that it would be helpful to have a session focused on the antiplatelets, clopidogrels, DOACs of the world. Some of our group members, noted that a lot of our patients are still on Coumadin for a very long period of time. Second theme was talking more about revisiting antipsychotics, and more particularly thinking about mental health diagnoses, mental health medications overall. We all know that there have been times in our clinical practice, and we've seen this in the literature, that we will get antipsychotics under control, but then perhaps another drug class creeps up on us. And some of my room's participants talked about how the presentation on anticonvulsants, it was super helpful and perhaps could also be of benefit to the group if that was revisited. And then lastly, talking more about the anticholinergic drugs and the benzos. So really we focused on anticoagulants and psychotropics in our room.
That's beautiful. That's beautiful. Can I ask a question of everybody? I really liked, Sabina, how your group did the case, and it almost felt like a grand rounds kind of thing. And what a rich way to learn. How could we ask you for cases, and when we fire this up again, make this work? What thoughts do you have on how we could make something like that work for you, where the story's a little more detailed clinically, just like you presented and just like you had in your film? Any thoughts on how we could make that work? I know we have the talking about anticonvulsants. I mean, right? We know how to do that. We've got that down. But I think there's something to the case presentation, especially when they're your cases. If we put out if we put out a request for cases, and look, these could be papers, but if we just put out a request for cases, do you think that's something people would respond to and say, yes, I'll take 10 minutes and talk about a complicated case, and this is what we learned?
I think that's a question to you. Would you all be willing to present a case? And Poonam, I'm sure you would be. You did such a good job, and Malik as well.
Yeah.
I think that when we have our next, or it could be part of a podcast as well, when we have our I learn best with cases, actually. If you're not talking systems approach, I learn my very best learning is done around cases. And I think that would be we will, before our next meeting, we will ask for volunteer to present a case and make that part of of an ongoing presentation. And you don't have to all scream here. Just one.
I have a feeling folks knew I was speaking to them, and they were afraid if they raised their hands that they knew I would come after them.
Yeah.
So no, it's not.
We'll get you.
Yeah, I would say that's definitely interesting, and I'd be happy to participate.
Great. Thank
Awesome.
you.
Awesome.
Yeah, that was
Perfect. So this is what we wanted to do today from you, our friends who've participated with us, some from the very beginning and some for the last few sessions. But we're kind of like a family with this. And anything you'd like to say before we close this chapter of D2D and start the next one? Cheryl.
I just would, for those people that just got started in the last few months, please go back and review the archives. It's very, very helpful to hear the whole process going through. So encourage you to take the time to do one every few days.
Thank you. Thank you.
Another thing I'd like to say is, as we go into phase 2, it would be helpful if there's a specific topic that you think we should focus a podcast on, or if you know anybody who you think would be a great guest, please feel free to reach out to us, because, you know, we're really relying, I think, on our network to also share the experts that you know and people that you think would be intriguing for everyone to listen to. So you can
Awesome.
put that in the chat, you can send us an email, but please keep in touch with all of that.
That's awesome. Thank you. Anyone else? Well, with that, and on behalf of my colleagues here from the AMDA D2D team, and to each and every one of you, thank you. Thank you for this rich experience. Stay with us when we bring up chapter 2 soon. And to each of you, a happy holidays and a very happy new year. Thank you so much.
And thank you for all that you have done for our precious and beloved patients. I really appreciate that. Thank you very much. Bye-bye.
Merry Christmas.
Merry Christmas. Thank you, everybody.
Bye-bye.
Thank you, everybody.
Bye-bye.
Yeah.